All right, okay, we will go ahead and get started. So good morning, everybody. Welcome to Medical Grand Rounds. We do have coffee in the room if people want to come down, even though our speaker is remote. So before we begin, I would like to respectfully acknowledge that we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enrich our vibrant community. And I'll just take this opportunity for our American colleagues to wish them a happy Thanksgiving. So delighted to introduce Dr. Satish Raj. Dr. Raj is the section chief of the Adult Cardiac Arrhythmia Group at the University of Calgary. After completing his core clinical training in Canada, he went to Vanderbilt for further training in autonomic physiology in 2002, and then moved back to the University of Calgary in 2014 and founded the Calgary Autonomic Investigation and Management Clinic. He's currently a professor of cardiac science at the University of Calgary's Cummings School of Medicine. He runs an active research program in human autonomic physiology. His primary research interests relate to understanding and better treating postural orthostatic tachycardia syndrome, vasovagal syncope, and orthostatic hypotension, all conditions that are very challenging for those of us that have dealt with them. And Dr. Raj really is a renowned international expert in this. So we're delighted to have him speaking to our group today. So I'll hand it over to you, Dr. Raj. Thank you.
Thank you for those kind words. I will say that in the spirit of land acknowledgement, I'm on Treaty 7 lands, not Treaty 6. And as an aside, I think there's a lawsuit that just started to try and get the Canadian government agreed compensation annually increased from $5 to something that reflects inflation over 150 years. For my American colleagues, happy Black Friday, perhaps an even more important day than Thanksgiving. Of course, if they really believe, they're probably in the stores now. My disclosures are listed here. There's nothing that's too related to what I'm going to talk about, except perhaps some of the funding. Some of the data I'm going to present actually relates to some heart and stroke funding that we have, and we've benefited from foundation funding from Dysautonomy International and standing up to POTS for some POTS research. What I will say about the consulting disclosures here are that this can be viewed as me being very sullied by industry, although there's not a lot of money in POTS yet, hopefully. But if I was giving this talk even 5 years ago, and certainly if I was giving it 10 years ago, none of the POTS consulting would have existed. And what this reflects is actually an increased interest from biotech and pharma on trying to help better understand what's going on with POTS and develop treatments. And so I think this is actually an exciting development, and hopefully if I give this talk 10 years from now, we'll see some of the fruits of industry actually coming to play with us, benefiting our patients. So I'll start with just what is it? What is postural orthostatic tachycardia syndrome, or POTS? The definition is listed here. It's been tweaked, but largely unchanged from a definition in a paper back in 1993. So it's about 30 years now. Basically, the physiologic hallmark of the disorder is that these patients have an excessive increase in heart rate on standing. That was, defined as an increase of 30 beats per minute in that initial paper. Obviously, anytime you draw a line in the sand, you can quibble over where that line should be. One challenge is that orthostatic tachycardia, physiologic orthostatic tachycardia, changes with age. In young people, it's a lot more, and as we get older, it's less. And that has a couple of implications. The first one was that in a lot of kids, teenagers, maybe even into preteens, there were a lot of people meeting this criteria that were otherwise perfectly well. And so the original criteria came out of Mayo and Rochester, Minnesota. The next generation at Mayo actually did a study, I think, in the school system where they brought kids in and looked at the orthostatic tachycardia and determined that it was high, and so redefined the criteria for kids, so 12 to 19, under 20, to require an increase of at least 40 beats per minute. But even that, is simplified for use and maybe not physiologically perfectly accurate. And the reason is because even between 20 and above 20, physiologic orthostatic tachycardia decreases with age. And so someone meeting, say, a heart rate increase of 32 beats per minute in a 22-year-old is much less impressive than a 32 beat per minute increase in a 50-year-old, because one would expect the orthostatic tachycardia to be less in a 50-year-old. So this orthostatic tachycardia has to occur in the absence of orthostatic hypotension. It doesn't mean that someone can't occasionally also have orthostatic hypotension, but if the only time you see tachycardia is in the setting of orthostatic hypotension, then we just assume that's a reflex orthostatic tachycardia from the orthostatic hypotension. It doesn't mean there's nothing wrong with the patient. Orthostatic hypotension is abnormal, but that's been a disorder that's been recognized for well over 100 years. And so there wasn't a desire to sort of redefine that or incorporate that. Now, everything I've defined up to now is physiology, right? It's POT, postural orthostatic tachycardia. The key to POTS is the S. It's a syndrome. It's a clinical syndrome where patients generally feel like crap when they're upright. They have orthostatic symptoms. They're worse upright. They're better when they lie down. If they don't have that, they don't have POTS, right? And one might say, well, why would they be seeing a physician if that's the case? And one of, I guess, the new challenges that we have are wearables. It seems like I might be one of the only people that still has a watch that tells time. Most of my patients have watches that tell them their heart rate. And so I have had patients come to me concerned about what their watch is telling them, even though they feel great. They don't need to be treated. Importantly, everything I've described up to now, the heart rates, the blood pressures, the symptoms when you're upright, and we'll get into what some of those symptoms are. Everything I've described actually will occur to most of us if we get a bad cold or a flu this winter. Acutely, this is how we respond. The difference in patients with POTS is that while, if we get sick, we will likely get better within a couple of days. These patients did not, right? So everything I've described has to be chronic. We used to require 6 months minimum. We've redefined that in the Canadian position statement to 3 months. The truth is, it probably doesn't make that much difference. If it doesn't resolve in 3 months, it's probably not going to resolve in the next 3 months. And then finally, this should be in the absence of another, specific or obvious cause for orthostatic tachycardia. And by that, I mean if someone has, for example, Addison's disease, and they're not able to hold on to fluid, and they are hypovolemic because of their Addison's, and they have orthostatic tachycardia, there's no point in diagnosing them with POTS as well. They'd be much better cared for if the Addison's were properly treated and they got better. So a few years ago, a few of us, through the auspices of the Canadian Cardiovascular Society, went out to create a position statement on POTS. And one of the things that we wanted to convey was that POTS requires both symptoms, lots of them, orthostatic symptoms typically, and orthostatic tachycardia. But as we were discussing this, we all had patients who had been misdiagnosed with POTS. In many cases, the problem was that they didn't quite meet criteria. And I suspect what would happen is that their physician, if they were to say you don't have POTS, what the patient will often hear is there's nothing wrong with you, which in many of these cases was clearly not the case. And so what we ended up having was some physicians diagnosing patients with POTS even though they didn't meet criteria. And sometimes that's because there was another explanation for the orthostatic tachycardia or the postural tachycardia. And so we created an ecosystem of, I guess, related disorders of orthostatic intolerance, and one was called postural tachycardia of other cause. But a bigger issue, I think, are those patients that don't quite meet the heart rate threshold. They have orthostatic symptoms, they feel unwell, but when measured, their heart rate doesn't make it above 30 beat per minute increase. And that's obviously a wide spectrum. Some people just miss, and some people miss by a lot. And so we coined a term for that called postural symptoms without tachycardia. Right? Again, it's probably not one thing, it's probably different things, but we needed a nomenclature to describe this. The other problem that we came across was that people in the POTS literature were often using the same terminology to talk about different things. So some people viewed POTS as almost a pure cardiovascular phenomenon. The patients had the heart rate issues in the absence of the blood pressure issues I discussed with some symptoms. And if we treated the heart rate and blood pressure issues, often we'd be able to improve those symptoms driven by those issues, and they'd be better. But there were other patients, and one could argue perhaps the majority of the patients, that actually often had other significant comorbid disorders or issues that drove their poor quality of life, such as significant gut issues where they had a gastroparesis-like presentation, or significant pain issues. And if those were their dominant symptoms, it was unlikely that even if we fixed their lightheadedness and their tachycardia issues, that we were going to significantly improve their symptoms. And that posed a problem in terms of trying to figure out response to treatment, for example. So we coined the term POTS and POTS plus, the plus being these other added features. And similarly, for the postural symptoms without tachycardia, or PSWT, we came up with the plus criteria, right? And this is just a way of, again, in terms of communicating that there are these other significant issues as well. And we list here some of the criteria that could fall into that plus category. So severe gastric problems, intractable vomiting. I don't mean someone's a little nauseated, but the people that can't keep things down. Severe constipation to the point of obstipation, neurogenic bladders. Associated disorders that are often seen that contribute significantly to a poor quality of life could include either hypermobile or Ehlers-Danlos syndrome of any sort, but usually hypermobile Ehlers-Danlos syndrome, something in the hypermobility spectrum disorders, mast cell activation disorders, patients with severe chronic fatigue, or other autoimmune issues. There are a series of other issues, and the treatments that I have aren't necessarily going to treat those issues. So it's just a placeholder to recognize that these other things need treatment, and they're going to drive how the patient feels overall. When we put together the CCS, Canadian Cardiovascular Society statement, the reviewers said, okay, great, you have these different disorders, a bit confusing. Please create a flow diagram. So this is what we came up with. So this is actually a little flow chart where, with yes or no answers to 3 or 4 questions, you could actually map your patient to the different diagnoses in this ecosystem of orthostatic intolerance. So I don't expect you to memorize this. The whole point of this is that this is a document that's freely available, and if you like these things, this could be sort of looked up easily or put on a pocket card if you're very old school, to try and sort of correctly position your patient in this algorithm. So coming back to POTS, there are several common symptoms that are listed here, and as a cardiologist, I've broken them down into things that I could blame on the heart on the left, and things that I have more trouble blaming on the heart on the right. So the stuff on the left, I think, is stuff you'd expect with a disorder with tachycardia in its name. The patients would have rapid heartbeats. They can complain of chest discomfort, shortness of breath, lightheadedness. But the stuff on the right are common symptoms in our patient that I have trouble blaming directly on the heart. So mental clouding or brain fog is often a term used by patients, headaches, nausea, tremulousness or shakiness. Now, all the symptoms in black in both groups are things that get worse when they're upright. But there are also non-positional symptoms that patients have and sometimes determine their quality of life. So almost everyone has exercise intolerance. Almost everyone I see is chronically fatigued. Not everyone I see would meet sort of a definition for chronic fatigue syndrome, but everyone is chronically fatigued. And most patients have significant sleep complaints. So obviously we don't ask them to do that upright. It's a feature. So not all the symptoms in POTS have to be positional, but there have to be dominant positional symptoms. I show you here a tilt test in a healthy control subject on the left and the POTS patient on the right, just to illustrate what we're looking at. The heart rate channel is on top, a blood pressure channel. This is a continuous blood pressure in the middle. And the bottom is just to show you when the tilt table is up and then when it went back down. So if you focus on the healthy control subject first, I guess the first key point I would make is that orthostatic tachycardia is physiologic. You can see the heart rate went up in this volunteer. So healthy control subjects, most of the time that meant grad student, but nonetheless, it went up and this is the normal response. If you focus on the blood pressure and compare the POTS patient blood pressure to the healthy control subject, you could certainly look at them and say the traces look different, right? The POTS patient, it's very spiky. It sort of looks like I do when I wake up in the morning in desperate need of a haircut, right? It's all over the place. But what you can't do is look at it and say the blood pressure is low in the POTS patient. If anything, I'd say the average pressure is marginally higher in the POTS patient than in the control subject here, right? So POTS is not fundamentally a disorder of hypotension or orthostatic hypotension. And then if you focus on the heart rate channel in the top right, the POTS patient's heart rate went up, just like the control subject, but it did it better. It went up more, and it went up early, and it kept going up. And this particular participant actually did not make it through the full 30-minute tilt protocol that we had. And we stopped because she told us to stop. And when she told us to stop, her heart rate was almost 180 beats per minute. Now, during that study, we were actually tracking symptoms every few minutes using, a score that eventually developed into what is now known as the Vanderbilt Orthostatic Symptom Score. And what you see here is in the healthy controls in black, they were fundamentally asymptomatic. Every once in a while, they'd get a little symptomatic, and then, they'd faint and they'd drop out and the symptoms would disappear from the group. In contrast, the POTS patients were symptomatic from the beginning, and they kept getting more symptomatic, and they kept telling me they're going to faint. They kept telling me that for 30 minutes. One interesting thing here is that, and I'm not showing this data, I probably should at some point, but a higher percentage of the healthy control subjects did not survive the 30-minute tilt. And by not survive, I mean we had to put the table down, not that they didn't survive, but they didn't make it through the 30-minute tilt in the POTS patients, right? So more of the POTS patients made it through 30 minutes without fainting than the healthy controls. And the important point from this is that POTS isn't fundamentally a fainting disorder. POTS is a feeling faint disorder. Patients tell you they would faint or they're about to faint, and a minority do. There's a minority, probably 20% of POTS patients can have vasovagal syncope as well, but most POTS patients don't faint. So, for years we had a sense of what a POTS patient looked like based on, patients that came and participated in our studies at Vanderbilt or that went to Mayo and they published their small series. But there was a concern that maybe this wasn't representative of the broader POTS population, right? Obviously, patients that are willing to travel across state lines and sometimes spend several days in a foreign city, maybe in a foreign hospital, aren't necessarily the same as those patients that are willing to go downtown to see their physician but not travel. And so, in conjunction with Dysautonomia International, which is the largest US-based POTS advocacy group, we put together a study that's colloquially called the Big POTS Survey. It's run ethics approval through Vanderbilt University, and we've had a sort of a collaboration between the University of Calgary, Vanderbilt, and Dysautonomia International now for the last decade looking at this. And the first paper from that survey was published in 2019. And what it showed us is that the POTS population more broadly, again, with the limitations of survey methodology, looked like what we thought it looked like. Over 90% of the population was female. Over 90% of the population was white. Now, this may be partly a function of the fact that the survey was done mainly by US participants. There's participation from around the world, but heavily US dominated. And the survey was only in English, right? So that certainly limits some other races. And so the race issue may be overstated here. If we look at the age of onset, the most common age, the mode, if you will, was 14. A little over half the patients actually developed their onset of symptoms that were later diagnosed with as POTS before the age of 18, and a little under half over the age of 18. There's a long tail, and this probably reflects the different underlying mechanisms that can result in an end phenotype of POTS. We had a laundry list of symptoms that we let patients endorse, and the first few are ones you'd expect for a disorder with tachycardia in its name. They endorse tachycardia, lightheadedness, presyncope. But the next few, almost as common, don't seem as cardiac. Over 90% had headaches. A similar number reported difficulty concentrating. Nausea was almost as common, memory problems. So the point here is that POTS isn't a cardiovascular disorder. It's actually a multi-system disorder with I guess, a fairly obvious cardiovascular component. And we talked about sort of the other medical conditions. About 83% described other significant things among what we listed. Migraine headaches, very common, 40%. Ehlers-Danlos syndrome, 25%. Irritable bowel, 30%. Gastroparesis, about 15%. Interestingly, vasovagal syncope, under 15%, under the gastroparesis number, right? And then, a potpourri of autoimmune diseases seen in about 15%. So what about quality of life? And so some of this work was done when I was at Vanderbilt with Kanika Bagai, who's a sleep neurologist, and was part of a broader sleep study. Now, these aren't our data. I show this because we did use the SF-36, which is a generic, quality of life tool or health-related quality of life tool. It has significant limitations, but the nice thing about the SF-36 is it's ubiquitous. It's been studied in everything. And I pulled data from the literature on a couple of disorders that are viewed as having a pretty poor quality of life, patients with chronic back pain in green and patients with end-stage renal disease on hemodialysis in purple, just so I could plot our data from our POTS patients up against it. And what you can see here is that our POTS patients have quality of life, self-reported, as all quality of life tools are, that are comparable to patients on dialysis, right? So these data don't speak to why that is. It doesn't speak to whether they're right or not, although I don't know how you could be wrong about a self-report of how you feel. But these patients generally feel miserable. So one of the questions that came up years ago was, is POTS a psychiatric disorder, right? And there was some work done by my wife, who was a research fellow in psychiatry before she became a psychiatrist. Now, when people say, is POTS a psychiatric disorder, really, the question they're asking is, are POTS patients crazy? And the short version is, some are, but it's actually no more than the US general population. So it's part of the study, they actually did long structured interviews and mapped, to the DSM-4 TR at the time. I know we're a bit ahead now, but they actually mapped to try and figure out, what diagnoses were available. And some people did meet depression criteria and anxiety criteria, but a fairly small percentage. They also looked at different psychometric tools. And one of the things they looked at, for example, was anxiety. And they used different tools, but with the anxiety sensitivity index, you'll see that the POTS patients had a higher anxiety score that put them in the mild anxiety category, actually, compared to normals here in black. Now, my wife actually very, happily told me that I did not qualify as normal, right? And this is actually one of the things you have to pay attention to, is that in many of these studies, the normals are screened. And so they're actually uber psychiatrically normal, if you will, and the POTS patients were worse. But if you compare the data for the POTS patients to the general population on the far right, they compare favorably. It's actually, it's probably the same. If anything, the point estimate's a little lower in the POTS patient than the US general population, right? So when looking at this, it's, are some POTS patients anxious? Absolutely. But that's probably the same as if you went to a heart function clinic or you went to any other sort of, general medical clinic and asked that question. The one thing that did come out of the study that was interesting was from an ADHD tool where they looked at inattention scores. And what they found was that the POTS patients here had higher scores than the normals, but also than the US general, the background population. It wasn't quite, their inattention wasn't quite as bad as patients with ADHD was another control group they used. But this was a problem, and this got us thinking because patients would complain about memory problems, and there wasn't a lot of work done on it at the time. And what this got us thinking about was the problem really memory, or was the problem inattention and an inability to process that memory properly? It turns out it's a bit more complicated. We've done a bit more work, and there are some memory problems, and it's not all memory, it's certain specific subtypes of memory, but inattention is a big part of the problem. Okay, so you diagnose POTS, now what? What do we do about it? In terms of investigations, in terms of the investigations for everyone, there aren't many, right? And people have different philosophies about this, but when we were doing the CCS position statement, the goal wasn't to run an exhaustive test of every medical test out there. But there are a few things that are critical. So the key to a diagnosis and quite frankly, the management of POTS is an excellent history. History, more history, a little more history still, and then a brief physical exam to rule out other things. one of the keys in a physical exam is to get a good set of orthostatic vital signs. And you have 10 minutes to reach the orthostatic tachycardia criteria. So you really, it takes time. You need sort of patients supine for at least a few minutes to get a good supine reading. You can get a seated reading or not. And then heart rates and blood pressures at 1, 3, 5, 7 or 8 minutes, and then 10 minutes. And that may sound silly, but you can't diagnose an orthostatic disorder without orthostatic vital signs. In terms of formal testing and blood work, there were some very basic things recommended in the CCS position statement. It was thought that a CBC was worthwhile to rule out severe anemia, a basic metabolic panel to rule out severe electrolyte disturbances, TSH, so you don't miss severe hyperthyroidism that could cause a sinus tachycardia. I don't think a cortisol was mentioned there. I think, a random cortisol is not unreasonable. Just to be clear, I'm not trying to pick up subtle signs of adrenal dysfunction, like is the adrenal gland a little punky or not. I'm trying to pick up a cortisol level of 0, right? So it doesn't happen often, but I have seen it, and you sort of feel like an idiot when you miss it. And so it's worth getting that. I don't get that excited about doing stim tests and things like that. You just want to make sure there's some. Everything else, I think, derives from the history in the initial exam. So if people aren't responding to treatment, we will often do autonomic testing. We sort of do that routinely in our clinic, but it's a referral clinic. You want to be confident that the patient has a structurally normal heart. That's the norm in POTS. If you can do that with a good exam, I don't think an echocardiogram is needed. But if you cannot, then it's worth clarifying. I've had a POTS patient refer to me when I was at Vanderbilt as someone who developed POTS in their pregnancy, and that does happen. But it turns out what she developed wasn't POTS. What she developed was a peripartum cardiomyopathy, right? So you don't want to miss that and treat it like POTS. So you want to be confident that the heart is structurally normal. And then there are other tools, repeated exercise assessments or blood volume assessments that may be useful. The blood volume assessments realistically are very difficult to get in Canada. So outside of a research context, probably not practical. In terms of treatment, I would argue that everyone should get a foundation of non-pharmacological treatment approaches, and then many patients, some patients, but in my clinic, certainly many patients require drug treatments on top of that. So the foundation of the non-pharmacological approaches are largely based on the fact that we think what is driving the orthostatic tachycardia in many cases, in most cases, is an inadequate cardiac venous return. Right, so that's actually hard to measure, with our tools. What we can measure is stroke volume. And if you make some assumptions, such as that the heart is pretty much structurally normal, then drops in stroke volume or low stroke volume are largely driven by not enough blood coming back to the heart. And so part of our strategy is to try and increase the amount of blood, and that's where dietary salt and water come in. Now, I think historically we've often, for many years, told people to take more salt and drink more water, but there actually were very little to no data to support it until recently. So this is a study that was my last big study when I was at Vanderbilt. We had NIH funding for a broader question over aldosterone and salt regulation in POTS. But in this study, we actually brought all female, but female POTS patients and sex and age matched controls into the research unit at Vanderbilt for 2 one-week stays. And during one of the weeks, basically, we fed them a very low sodium diet, as low as we could. We had a metabolic kitchen that helped us. And during the other week, which was at least a month apart, so we tried to get it around the same phase of their menstrual cycle, we fed them a very high sodium diet. And for the first 6 days, we did nothing besides feed them because we wanted to get them into steady state. And then we studied them and we assessed blood volume formally using, nuclear medicine techniques. We did stand tests and looked at the heart rates, and we looked at norepinephrine levels in the blood, supine and standing, norepinephrine being the neurotransmitter in the sympathetic nervous system. And what we found was that when we went from a low sodium to a high sodium diet, we increased the blood volume, specifically the liquid part of blood, the plasma. And with that, we actually blunted the increase in norepinephrine on standing. So this cartoon is probably incorrect when it says the norepinephrine level went down with the high sodium. It didn't go up as much. is probably more correct. It still went up on standing, that's physiologic, but it didn't go up as much. And the heart rate then didn't go up as much either, right? So we blunted the orthostatic tachycardia. So the short version of this is that actually by putting patients on a high salt diet, it did what we thought it would do. It actually increased blood volume and it decreased sympathetic tone, it decreased the orthostatic tachycardia, and there's a strong trend towards improvement in symptoms. So that's great. That's, I don't have access to metabolic kitchens in my clinic. And so, I guess the question is, what do we actually do? So this is actually my approach in clinic. So the first thing is I actually try and get my patients to drink a minimum of 3 liters of water per day. And pretty much that means, what I tell them to do is I want them to have a water bottle, right? And when I say a water bottle, I mean one water bottle. So I don't know if any of you are football fans, but Thanksgiving Thursday in the States means lots of NFL football. I actually had a chance to watch a couple of the games yesterday, and there's a saying in football that if you have 3 quarterbacks, you don't have a quarterback, right? I think it's the same with the water bottle. I don't want them to have a drawer full of water bottles. I want them to have one. I want it to be one that they like. I want it to be one that they have with them all the time. I tell them that I want that water bottle in their hand all the time. I want people to think I've sutured it into their hand. If they come to clinic, I actually ask them to show me their water bottle. And if they say they left it in the car, that's a fail. If there's a family portrait, I want the patient, their spouse, their kids, and the water bottle in the photo, right? Literally, it seems like a ridiculous thing to say, but the point is that 3 liters is a lot. But it's absolutely doable if they have the bottle with them all the time. And if they only have one water bottle, they can also figure out fairly quickly how big it is. And if it's, say, a 750, they need at least 4 of those a day. If it's a liter, they need at least 3 a day. And you don't have to sit there and add up different bits from, this and that. Between the Heart Rhythm Society POT statement from 2015 and the CCS statement, basically about 10 grams per day of salt is recommended. Now, the problem is that I actually can't figure out how to count that with any accuracy, and so I can't tell my patients how to do it. But a teaspoon of salt is about 5 grams. So I've converted it to say, okay, we need to get about 2 teaspoons, 2 extra teaspoons of salt into you. And the simplest way to do it is salt, not salt tablets. It's regular salt. And so what I'll do is I've actually sort of asked them to follow the Ziploc bag approach, if you will, to take the teaspoons of salt, the 2 teaspoons of salt in the morning and put it in some container. It can be a Ziploc bag, it can be a plastic container, but something they'll keep with them through the day. And then instead of adding salt from random sources, add it from the bag. And that way you have a semi-quantified sense of how much they're getting in. As I mentioned, I don't like salt tablets. Regular uncoated salt tablets that you can sort of buy over the counter or at the local pharmacies um, tend to cause more gut grief. They only have one advantage, and that is you don't have to taste all of the salt. You just taste the salt on the surface. And so if someone hates the taste, it's an option. But routinely, it's not a great option. There are some patients that just can't tolerate the salt, even with diet. And if that's the case, there are actually gel-coated tablets. And so one commonly used brand is called Vitacium by a company called Salt Stick. It's available on Amazon. It is fairly well tolerated. It's absorbed beyond the stomach, and the vast majority of patients don't get gut grief with it. The problem is each tablet contains 250 milligrams of sodium. You need about 4.5 grams of sodium a day to get to 10 grams of salt. So that's 18 tablets a day, if that's your only source. You go through the tablets quickly. It gets expensive, and that's the problem with the potassium. So, regular table salt, even fancy Himalayan sea salt, fancy kosher salts, right? These are going to be cheaper than drugs and often, best tolerated and cheapest way to go. The next, approach is compression garments. And the theory here is that, again, we want to get more blood back to the heart. And these patients have most of their problems when they're standing up, not when they're lying down. And so what happens when we stand is gravity affects us and fluid shifts from our chest to below our chest. And the goal of the compression garments is not to get rid of that, but to decrease that shift, right? Mitigate that shift, have more of the blood coming back to the chest, back to the heart, where it's pumped out again. And so a few years back, Kate Bourne, who was a PhD student of mine at the time, currently a med student in Calgary, did a study in the lab where we used a segmental compression garment suit, I guess. And did recurrent tilt table tests in our lab on POTS patients. And what we showed is that full compression, as you can see here in the bottom, in violet, blunted the heart rate increase on tilt compared to no compression. And in fact, we didn't just look at full and no, we actually had 4 different compression modalities, if you will, full and none on the extremes, but we had an abdominal compression, which was sort of a bicycle shorts, abdomen and upper thigh compression, and we had a leg compression, which is more calf compression, what people often end up hearing when you say wear compression garments, they hear compression socks. And what we showed is that they're in a dose-dependent manner, full compression was better than abdominal compression, but abdominal is almost as good. Leg compression, almost as bad as no compression, but in a dose-dependent manner, symptoms varied. And the symptom scores, the VOS score, if you will, actually related very tightly to the effect of the compression on lowering the, or on the heart rate change on when upright, right? So the full compression lowered that heart rate change more and improved symptoms more. So I should say one more thing about this. So this is great. The compression suit that we used was made of neoprene and Velcro, and no one in the right mind would ever wear it unless under medical duress. But just in the last week, Kate has published a follow-up paper. It's out in JACC Electrophysiology. I don't think it's been an issue yet, but it's actually available online as of yesterday, I think. Where we actually did a follow-up study using commercial tights, commercial waist-high compression. So these are garments people had, some were prescription, many were not prescription. What I usually recommend people to do is to go to a sporting goods store and purchase high-end athletic wear like triathlon tights. The high-end garments will have ratings of 15 to 18 millimeters of mercury, less than what we can prescribe. But the trade-off is they're a bit more comfortable and they're a bit more fashionable, right? So I'm old, I acknowledge that. I grew up in an era where we thought tights were underwear. My daughter is not old and she tells me I'm wrong, right? I mean, she wears tights and that's what she wears. And my patients look more like my daughter than me. And so part of the goal here is to get garments that people will wear. And so the commercial garments tend to be used more. So there are now data that they work. Now, the one caveat is that even with what passes for summer here in Edmonton and Calgary, my patients tell me that they overheat and they can't wear the garments because it gets too hot, the full-on tights. And so our backup plan for a few years has been things like body shaping garments like Spanx with a focus on compression of the abdomen and the basically upper thigh to bottom of the rib cage, focus on the abdominal compression. Leaving the rest of the skin uncovered and so less overheating. Until recently, there have been no data that helps. But in fact, Kate's follow-up study, which we're in the process of submitting for publication right now, shows that that too works. It doesn't work quite as well as the full compression. The full-on tights work a little better, but the abdominal compression certainly do work, and they're an excellent option when the full-on tights aren't an option, either because of fashion. You're wearing, patient has to go out in a dress and the tights under the dress look silly, and so they won't wear it, or temperature, heat, thermoregulation problems. And then finally, the final pillar in terms of non-pharmacological approaches is exercise. There have been a few studies, but the best one came out of Dallas almost 15 years ago. Chifu was the first author on it. They did a before and after study and assessed just about everything physiologically. It was really a tour de force. They showed that a 3 to 6 month exercise program in POTS patients increased fitness levels, increased blood volumes, formally assessed, increased cardiac mass. They did cardiac MRIs showing heart sizes enlarged, stroke volume increased. They put catheters in and measured filling pressures. They did sympathetic nerve activity recordings where they put needles in sympathetic nerves and showed that it could decrease excess sympathetic nerve activity. All of those things, most of my patients don't care about. I find it quite cool, but they don't care. But it decreased orthostatic tachycardia, it decreased the heart rate increase on standing, and they do care about that because they can measure that. And most importantly, everyone that completed the protocol, which in fairness wasn't the same as everyone that started, but everyone that completed the protocol reported an improvement in quality of life with the SF-36. Some a lot, some a little. I don't want to sell this as a cure for POTS. It's not. It's a treatment, but it's actually, I think, an important part of treatment. So in terms of how to do this, right, in this study, they had calendars and they had, exercise trainers. I don't have any of that. So I give my patients principles to follow, right? So this is largely based on aerobic reconditioning. This isn't about, stretching and stuff like that. You can do that as well. If there's no muscle, if the patient's just skin and bones, they did encourage some resistance training to build up a little bit of muscle bulk on the thighs, but it's mainly aerobic. The key to their training mode was it has to be regular. They needed at least 4 days a week. I'll try and get my patients to try for 5 or 6 days a week because even with the best laid plans and intents, you're going to miss days here and there. And fairly quickly, every session needed to be 30 minutes. Eventually, they built it up to 45 or 60, but early on, 30 minutes. The most important thing that they did, the cleverest thing was they said, no, they forbid upright exercises. Now, if you tell your patients to exercise and you ask them what they heard or what they'll do if they'll do it, it's almost always walking, treadmills, evil elliptical things, right? Things where they're vertical. And if they have a disorder where they get their heart rate up and feel horrible when they stand up, they're not going to last very long. And so they said, no, none of that in the beginning. Later on, they could graduate to that if they want. But initially, they recommended the use of rowing machines. And if that didn't work, then recumbent cycles and swimming were backup options. So I don't know about Edmonton. Certainly swimming pools, outdoor pools in Calgary are ice rinks. I suspect they are in Edmonton as well. And there aren't a lot of indoor pools. There aren't enough, right? So most of my patients end up using a rowing machine or a recumbent cycle. And the key is to let them start slowly, right? So I want to get to 30 minutes, but turn the resistance on the rowing machine or the recumbent cycle all the way down and go as slowly as you need to go. They need to go as slowly as they need to go to get to 30 minutes. Now, this final point is perhaps the most important. It's about managing expectations. I initially had patients coming back saying, this isn't working for me. And I had to go back to Dr. Fu and say, what am I doing wrong? And what she said is, we said everyone got better after 3 to 6 months. We didn't say when. And it turns out it can take up to 6 weeks before the patients start to notice any improvement with exercise. And in the interim, they will often feel worse. There's often post-exertional malaise. But once they get to that point between 4 and 6 weeks, it's like a light switch flips. And then when they miss days of exercise, they feel worse. So this is not an easy treatment and it's not a fast treatment. There's light at the end of the tunnel, but it's a long tunnel. So finally, a few words on drugs on top of this. Intravenous saline works acutely. This is a study from a long time ago now from Juris Jacob when he was at Vanderbilt, and it showed, if you look at the far right, that after a liter of saline, the orthostatic tachycardia was cut in half from about 32 or 33 beats per minute down to 16, right? It works brilliantly. If someone is in distress, they end up in the emergency room, they're doing really poorly, someone's calling you saying, please consider admitting them. My recommendation is to give them a couple of liters of saline and see how they do. And most patients will acutely feel better and probably well enough they don't need to come in. The problem is when we talk about doing this chronically. And the problem is usually not the saline. If they're only getting a liter a day or even 2 liters a day, the saline probably not going to cause problems. The problem is access. Right? Initially, for a while, you can do this peripherally with peripheral IVs. They will lose that ability if you keep accessing it. And then you start down a slippery slope going to PICC lines and then portacaths. And the concern is around portacath complications. And for that reason, both the Heart Rhythm Society in 2015 cited here, but also the CCS statement recommend against regular intravenous infusions of saline or anything else, but saline is what was discussed specifically. DDAVP, desmopressin, is a drug we give to little kids that wet their bed. It promotes free water retention. So it turns out this can actually lower the orthostatic tachycardia as well in POTS patients. I've typically used this rarely, but use this as a special event drug. Someone wants to go to a movie on Thursday night with their friends. They're not sure how they're going to feel. If they take this Thursday afternoon with water and retain the water, often they feel a bit better. Some people use it nightly, like 0.2 milligrams, not too much, 0.2 milligrams every night to help with the free water retention. Now, where you have to be careful is that we don't tell 5-year-old kids that wet their bed to drink 3 liters of water a day. right? And this can cause hyponatremia. So if you're going to put patients on this, you need to measure their sodium levels periodically, probably at least weekly in the beginning, to make sure they're not getting hyponatremic. Blair Grubb is a cardiologist in Toledo with a huge experience, and he actually started using this nightly in a bunch of patients and set it up like a Coumadin clinic back in the day, where there'd be a standing order for the sodiums. They'd come in, his nurse would look at it. And what he said is that he only had a problem with one patient, and that was a patient that felt so good with one that she thought four would be better. But the patients that stuck to 0.2 milligrams a day or one tablet didn't have any problems with hyponatremia. Mitidrine is a pressor agent. It's a prodrug that causes vessels to squish a little, supports blood pressure a little. You can see it lower the heart rate in POTS. It can be effective, but a modest effect compared to the saline. Beta blockers, you have a disorder with high heart rate. Certainly we can lower that, right? But there have been lots of patients reporting they don't tolerate it. So when we were at Vanderbilt, we brought patients into our research unit, and they tell us they wouldn't tolerate it. But when we studied propranolol 20 milligrams, it was typically the winner. It was the best drug in terms of lowering the heart rate, lowering the orthostatic tachycardia, and improving symptoms. And it was actually our research nurse, Bonnie, that sort of had the insight, because we were trying to figure out why patients would say they don't like it or they didn't tolerate beta blockers, and then turns out they like the propranolol best. And she said, well, we typically use low doses of drugs in our patients. Maybe it's a dose issue. In fact, when we compared low dose propranolol to a fuller dose of propranolol, symptoms got worse with more beta blockade. So the key to beta blockade is to use a tiny amount. And again, propranolol may be a little different than others because it gets into the brain and it blocks beta-2's effect, but the key is mainly just to take the edge off the heart rate, not to correct the heart rate. More recently, there's been a study out of San Diego looking at ivabradine. It's a funny channel blocker. It's approved in Canada for a subtype of heart failure with reduced ejection fraction. But it has lowered heart rate and improved symptoms in a cohort of POTS patients compared to placebo. Insurance coverage is sometimes difficult, so it's definitely more expensive than propranolol, but it's another option. Whether it's better than propranolol or not is actually an open question, and we have a crossover study we're doing right now of propranolol, ivabradine, and placebo, so 1 month of each with visits to the lab near the end of every phase. So we'll get back to you hopefully within a year. And the final thing I'll talk about is our norepinephrine transport blockers, or SNRI drugs. Not because you should use them, but because you should not use them or be careful with them. This is the only drug in our study. We used atomoxetine or Strattera as our model drug for blocking the norepinephrine transporter, but it raises heart rate, both standing and seated. It raised the orthostatic tachycardia and it worsened symptoms. And this really was the only drug we ever studied that did that. There are lots, I can get into why that is. There are lots of reasons why this is a problem. This class is problematic in this patient population, but there are a lot of drugs in the psychiatric space and also in the fibromyalgia space, quite frankly, that block the norepinephrine transporter and can make these patients worse. And finally, there's been a study published earlier this year on vagal nerve stimulators. This one that targets the tragus branch of the vagus nerve that showed that it did lower the heart rate, with 2 months of treatment. This is a small single center study. We've actually put in grants, and I'm involved in a couple of grant applications right now to study this in a larger multi-center way, but we may have sort of novel and different treatments for POTS in a few years. So I'll end there by saying that POTS is a chronic disorder associated with significant disability. It's actually not a disease, it's a syndrome. It's probably multiple disease pathophysiologies underneath. The treatment principles are exercise, blood volume expansion, heart rate control. And I didn't talk about this, but it's worth remembering that all these patients have a chronic illness and they need to learn to live with a chronic illness. And as physicians, I think it's part of our job is to point out that and give them permission to do that, right? A lot of patients also have this idea that it's either in their body or in their head. And the truth is it's both. And so they need to deal with both aspects of it. Thank you very much.
I turned on the audio first so you could hear some of the clapping anyways. Thank you, Dr. Raj. That was just so practical and so comprehensive. Really appreciate it. I'm going to kick it off with the questions, if that's okay. You clearly demonstrated this overwhelming gender predisposition. And I wonder if you can comment a little bit on that, what your thoughts are about why so predominant, and also a little bit of in terms of natural history. Like, is there, you know, postmenopausally, is there some improvement that happens? Is there ever any kind of burning out, if you will, of the condition that happens? And yeah, so just a two-parter.
Yeah, so the first question had to do with the sex, skew, I guess, right? It's overwhelmingly affects females. And the truth is, I don't think people know for sure, right? The fact that there's this big bump around age 14 in girls primarily, right, would suggest that there may be a hormonal effect. And the truth is that hasn't been fully and properly studied. Of note, a guy named Jeff Boris, who used to be at Children's Hospital in Pennsylvania, actually published a case series of 3 patients that transitioned from female to male. So we're getting exogenous testosterone, and in their cases, the symptoms actually improved a bit. So maybe part of it's hormone related, sex hormone related. Obviously, there are lots of other hormones that are varied. So that may be part of it. Out of the Dallas exercise study, one of the theories is that it may be a heart size, the stroke volume heart size issue and how much buffer you have. So on average, men are bigger than women, or males are bigger than females. And so are their hearts, and so is their stroke volume. If you draw distribution curves, they're overlapping, right? But the male curve is shifted over a little bit. And so Ben Levine's argument, and he was the senior author on the exercise study, is that, well, if you have a critical low threshold, there are more females in that tail that are closer to that or at that than males in the tail, and that may be part of it. But the truth is we don't know for sure. That was the first question about sex. The second question was about right?
Yeah, the burning out.
Yeah, so 2 things. Like in the pediatric literature, the pediatricians often say that, a lot of kids will grow out of this. And that's possible. It's possible, right? The truth is I don't see kids, so I can't comment for sure. But when I look at the literature that they've published, it is crap, right? I'm actually more concerned that it's not so much the kids grow out of their pots as they grow out of their pediatricians. And they end up seeing the internists, and the pediatricians then say, well, they're better, they're not seeing me anymore. The issue about what happens in the long run is actually something that we've just recently tried to address. So we actually did a study, a survey study at Vanderbilt, where we went back and actually asked patients that we first saw in the late 90s and early 2000s, and who've had POTS for at least 10 years, but on average over 20 years, actually. But I think we had 40 to 45 patients respond, and asked them about their symptoms at presentation, their symptoms when they first came to Vanderbilt, and now. And there was, variability. And this is a paper that actually we're going to be submitting. We presented at the autonomic meeting earlier this month, and we're going to be submitting soon for publication. And what we found was that of the 44, 45, exactly 1 person said that they were cured, that their POTS was gone. So for most people, it doesn't just go away, but about half reported improvement and about half didn't. And some of it actually, and there were some people that had a variable course. And so it doesn't all go away, but I think we can treat, but it's not as simple as it disappears. Now, we don't diagnose it as much in older people, and I suspect that has to do with the fact that orthostatic tachycardia decreases with increasing age. So if we're saying the 30 beats is the key, and above 20, it's the 30 beats is the threshold, it's harder to meet that criteria for a 50-year-old than it is for a 20-year-old. And that may be part of why we don't see it as much. But people diagnosed before that, do they get better at menopause? Not necessarily, right? I mean, there may be some, but not clear improvement. It's certainly not that it goes away magically at 50.
Before I go online, yeah, there's just a couple of questions here. So, Dr. Wake?
So,
yeah.
Are there any data on pre-morbid exercise patterns in these individuals? I assume that they're kind of deconditioned when they present, but are they sedentary to start with?
Did you hear that?
Yeah,
so
I think it had to do with the activity level and exercise level before they got sick. So I don't know. When you said are there data, I'm not sure. I could actually look in the Big Pot survey if we thought to ask that or not specifically. I can tell you anecdotally. Obviously, there's a spectrum, right? There are people like me that probably should have been exercising more before, but I'd say a high percentage, and probably the majority of patients I see were actually quite active before, on sports teams or running ridiculous lengths that they probably shouldn't, before they got sick. So it's not, I think it would be incorrect for the vast majority to say that they were deconditioned and fell into this. I think, when people get sick, you tend not to do as much, right? I think that's true for everyone. They don't do as much as they were doing before they got sick. And so can secondary deconditioning kick in? And could that be what the exercise is helping with? Absolutely. That's not the same as saying that's what's causing the POTS. And I don't think you can, just to be clear, I think exercise is a part of treatment. I don't think you can train out of it, right? My POTS patients that are exercising, they, still often have to do other things like the salt and water, and most are still on drugs. My focus is trying to get them where they can function as well as they can, whatever that means for them, not necessarily to cure them, if that makes sense.
some really good questions online. So just confirming here, if a patient with POTS becomes or already is hypertensive, would you recommend taking taking propranolol but no to diuretics?
So I don't recommend diuretics for any of my patients, right? So generally speaking, if you have someone with an orthostatic disorder and you want to make it worse, give them a diuretic. Because volume is so important, right? Remember if you think about it, a large part of our strategy is on trying to increase blood back to the heart. And diuretics run counter to that. Now, you might say, okay, well, we won't give Lasix, but there are other versions of this. And so one of the things that people don't think about is that there's a birth control agent that's not as commonly used now, but about 10 or 15 years ago was all the rage, called Yaz, or Yasmin. It was another similar drug. And it got into trouble with the lawyers because of PE risk, but I'm not sure that's unique to Yaz. But one of the interesting things about this drug, and there are three drugs that did this, but Yaz was the most famous, is the progesterone agent is a drug called drospirenone, and that's actually a spironolactone analog, right? And so, again, there's not good data on it, but anecdotally, I will actually get my patients to switch off of Yaz onto another birth control agent that doesn't have drospirenone, and that can sometimes help. The other issue with this is that spironolactone is sometimes used to treat acne. And if patients are on this, I need to get them off. And that definitely does help. That's actually sometimes the hardest thing to do, because I think some of the patients would rather actually not be able to stand up than have bad acne. But, I'm told by my endocrinology colleagues there are other good approaches for acne that don't necessarily have a diuretic effect.
Yeah, this is a tough question. The next one is also about multi-drugs that I'm going to skip over and actually ask you about this biomarkers. So do any of the interventions try change blood biomarkers if you've looked at it, like proBNP, ANP, and others that are sensitive to volume pressure shifts? And do urine electrolytes change?
Um, So I'm not sure there have been some specific studies that have looked at bits and bobs. So urine electrolytes. So I will say that 24-hour urines. I don't think this is actually what the question was asking, but 24-hour urines can be used to actually assess how much salt intake there is, right? So if you're concerned they're not getting in enough salt, there are approaches where people will use 24-hour urines. I rarely do, because you usually just try and get them to take the patients to take more salt. But in our studies, we are using 24-hour urines to assess that, and it's a good marker of intake. It's not perfect, but it's pretty good. In terms of the other biomarkers, there have been studies showing high levels of CRP and IL-6 and things like that. There's a lot of interest in autoimmunity, but I'm not sure there are markers that we use. For the most part, clinically, we have not been measuring ANP or BNPs, but as an aside, there's actually one of my consulting issues is with a company called Regeneron, who are actually in earlier development. Like there's a phase 2 study actually looking at that's going to be starting soon, looking at an inhibitor of ANP, I believe. So the whole idea is to try, they have a peptide inhibitor that will block ANP to decrease diuresis and increase blood volume and hopefully decrease the orthostatic tachycardia. So they are probably collecting some data on some of these biomarkers because it directly affects their drug pathway.
The interesting information. We have come to the end of the hour. I know there's lots of questions online, but we are at the end. I have personally reached out to Dr. Raj by email, and he's actually responded regarding a patient. So I'm kind of gonna volunteer your services if people have, because these are very difficult patients, and you've given us a really nice practical approach here. And I, certainly we've recorded this and we'll point to that, but I'm sure you come across some very challenging patients that you've got your approach to, and thank you for sharing your wisdom with us.
Thank you
Take
for
care.
having me.
Stay warm.
You too. Bye-bye.